Good. All right, everyone, thanks for joining MacEmerg regional rounds for April 29, 2021. Before we begin and introduce our esteemed guest, I'm just going to let you know, as you know, that our evaluation for this talk is going to be in the chat box, so please go and complete the evaluation. Also, there will be a QR code at the end from our regional round speaker that you can also fill out. This really helps our regional round speakers to see their feedback, amend as necessary, and also give them a really great pat on the back for their hard work. Like I said, so we'll get started. So thanks everyone for joining. Today we're going to have Dr. Joanna Dionne, who is an amazing speaker and actually someone that I worked with when I was an ICU as a resident. So, excited to have her here. And she's going to be speaking about GI emergencies. So some of the things that she will talk about is management of acute liver failure, portal hypertensive bleeds, as well as kind of dealing with upper GI bleeds, which we all know and have seen and are very scary. Just to introduce her guest, she is a gastroenterologist, intensivist, methodologist at the Hamilton Health Sciences and McMaster University. She has many degrees. She's a graduate of Masters of Science in Health Research Methods program at Mac, as well as she completed her Bachelor of Nursing from the University of New Brunswick prior to pursuing graduate training in Epidemiology at McMaster. She is also finished her medical degree, internal medicine residency, gastroenterology, and critical care medicine fellowships at McMaster, and now also currently pursuing a PhD in health research methods in the CI program. So I'm going to stop there because there's a lot. But thanks for joining us, and thanks everyone for joining Regional Rounds. Your floor is yours, Joe.
Wonderful. Thanks so much, everyone. This is a real honor to get to talk with you today about some of my favorite topics. GI emergencies are like what I like to call it, what keeps you up at night when badness hits the fan. So all the things that make people super nervous. So I'm going to go through management of acute liver failure, as well as management of variceal bleeding, how to use a Minnesota Blakemore. Most of the eMERGE group know this very well, but I thought it was worth going over for the sake of the talk. And then an update on management of non-variceal bleeding that's pertinent to the emergency room department. So objectives after this talk, you'll be able to recognize and manage acute liver failure, portal hypertensive bleeds, and upper GI bleeds, which you're already able to manage. So conflicts of interest. So in addition to my clinical work, I'm a methodologist for the liver management guidelines for the Society of Critical Care Medicine. I'm a methodologist and a GI panel member for the transfusion guidelines as part of the European Society of Intensive Care Medicine. I'm a methodologist for Canadian Blood Services for the Alcohol and Liver Disease Guideline and Renal Transplant Extended Criteria Guideline. And I've also received research funding as a principal investigator from PSI and the Canadian Association of Gastroenterology. So acute liver failure, this is probably the one that freaks people out the most at every level, from critical care, gastroenterology, emergency medicine, because these people get very sick very fast. So the papers you really need to be aware that out there are the ASLD position paper, which is actually quite old now. It's 2011. And the EASL guidelines are the ones I reference in this talk. They are the most up-to-date and I think most user-friendly for those not in the field of hepatology. So when you're talking about acute liver failure, it's really important to focus on definitions of what acute liver failure is. So acute liver failure is a term that describes patients who have no underlying liver disease, who present with acute liver dysfunction, so synthetic dysfunction, transaminitis. And then there's the acute on chronic liver failure, which is beyond the scope of this talk in particular. I'd be happy to come back and chat with you all about this. And this occurs when there's an acute deterioration in hepatic dysfunction in patients who already have cirrhosis and already diagnosed with cirrhosis. So we'll be focusing on ALF for the purpose of this talk. So ALF is actually a very specific syndrome and it's quite rare. You see it a couple times a year, sometimes more. It kind of fluctuates by season. And it's characterized by an acute deterioration of liver function without chronic liver disease. And it's on a spectrum from acute liver injury. So that's where you have no underlying liver disease, but you have liver damage as evidenced by transaminitis 2 to 3 times up of the upper limit of normal, and impaired liver function. So you have jaundice and you have coagulopathy. And usually that's within 12 weeks. If you have hepatic encephalopathy, that is crucial for the diagnosis of ALF, and the mental alterations can be quite subtle if you're not looking for it and screening for it. So subclassifications of ALF are on a spectrum. So greater than 28 weeks really is the chronic liver disease territory, and 0 to 12 weeks, you have your hyperacute, acute, and your subacute ALF. And that differs based on the severity of your coagulopathy, the severity of your jaundice, the degree of intracranial hypertension that you experience, chance of spontaneous recovery, as well as the cause usually is indicative. So in the hyperacute, you have Tylenol or paracetamol, Hep A, Hep E, co-infection, and acute, more Hep B, and then subacute has kind of the poorest outcome, and that's in the non-paracetamol or Tylenol drug injury. So the principal etiology of ALF, it is very wide, and this is very good for exams, if any of you are studying or have just finished your exams, in terms of the etiologies at ALF. So it's particularly at the emergency level, because you guys are going to be seeing these patients first. So drugs, always think it's drugs, take a very detailed drug history, know when it was started, if it was increased, what the dose was taking, and then really be mindful of screening for naturopathic medications because they're not unregulated or travel. Viruses, what we see locally mostly is acute Hep A, and there have been some cases in Hamilton of acute Hep A fairly recently. Hep B with a co-infection, so a Hep E, Hep D, though that's fairly rare. And then CMV, HSV, and varicella can also cause ALF, but rare. And dengue is something they like to test on exams. I've not seen dengue myself, but there you go. Toxins, so Amanita phalloides, so mushrooms, so those that are campers and foragers. Others, Wilson's disease, autoimmune, lymphoma, malignancy, HLH. We do see this not uncommonly at the Juravinski. Pregnancy, I hope you know she's pregnant. In internal medicine, everyone's too old to be pregnant. So you get preeclampsia, liver rupture, HELP, fatty liver of pregnancy or acute fatty liver of pregnancy. And then vascular is really the Budd-Chiari and hypoxic hepatitis. So in terms of management of the acute liver failure patient, so it's really ABC. So you want to make sure that they're hemodynamically stable. If they need to be resuscitated, they are so. You want to exclude cirrhosis and make sure you screen for alcohol-induced lung injury. You want to initiate early discussion with gastroenterology as well as liver transplant. So the liver transplant centers for us are London and Toronto. And for a while with COVID, London was closed. So you really need to make sure upfront all the people that need to be notified are notified, because these patients can decompensate very quickly within a span of a couple hours. You want to screen intensively and repetitively for hepatic encephalopathy, and you want to try to determine the etiology. So some of this workup will start in the emergency room department, some of it will conclude in the ICU, and this helps to guide treatment and determine prognosis. And you want to assess suitability for liver transplantation. So that's not on the emergency room department, and really it should be at the level of a liver transplant center to say if someone is a candidate or not a candidate. And you want to make sure you transfer a patient to a specialized unit. Poor prognostic factors is if the patient has an INR greater than 1.5 and onset of hepatic encephalopathy or other poor features. So you want to exclude cirrhosis, you want to exclude alcohol-induced liver injury, and you want to get the people involved early who should be involved. So that's, gastroenterology, who should be making the initial assessment with liver transplant and put to a step-down unit or an ICU for monitoring. So in terms of the etiologies, so the green area here is possible indications for emergency and transplantation. So that's drug-induced injury, acute viral hepatitis, specific, most commonly you see Hep A in that category, toxin-induced, Budd-Chiari, autoimmune, and pregnancy. And then ones that really are not a candidates for emergency liver transplant are those with hematological disorders, metabolic disease, infiltrative disease, and lymphoma. So in terms of the etiology, sometimes it can be hard to tease out who has what. So really the devil's in the details and history taking. So paracetamol, they usually have very high levels of transaminitis where relatively lower bilirubin levels in comparison, and it's rapidly progressive, and they develop acidosis and renal impairment. You can also see non-subacute paracetamol in people who have maybe some underlying synthetic dysfunction or have co-use of alcohol. So Budd-Chiari's abdominal pain, ascites, hepatic encephalopathy, those are usually the traditional signs. Wilson's, I've never seen a Wilson's case myself, but it's usually a young person who has Coombs negative hemolytic anemia and a psychiatric overtone. And then mushroom poisoning usually have AKI plus GI, other GI symptoms, and autoimmune, other symptoms of autoimmune diseases. So infiltrative, malignant infiltration of the liver and acute ischemic injury are not indications for transplantation. And sometimes it is difficult to tease out if someone's had an acute ischemic injury versus a drug injury. Usually with acute ischemic injury, they have injury to other vital organs, such as renal failure. They've had documented hypotension.
I'm on a meeting, maybe. I will look it after.
So in terms of drug-induced,
Joe, you muted yourself.
oh, not sure how I did that. So drug-induced liver injury is the most frequent cause of severe acute liver injury and acute liver failure. So you really have to be diligent in taking a good history of drugs, dosing, changes, herbals, street drugs as well. And you want to do a toxin screen and determine the Tylenol level upfront and start an acetylcysteine. As a someone with liver interest and as a gastroenterologist, I have very low threshold for giving an acetylcysteine. Has very few complications, and in these patients, it can, even in non-acetaminophen toxicity, it can actually be helpful. And prognosis is worse in patients who have paracetamol, especially those that have staggered injury. So it wasn't just one overdose, it was multiple overuses. So viral and autoimmune ALF, you want to look for hepatitis B, hepatitis A, HSV 1 and 2, and look for varicella. And you want to make sure there's no underlying autoimmune disease. So uncommon etiologies. So HELP and acute fatty liver of pregnancy. They're rare, but they're really scary when they happen. Budd-Chiari and Wilson's, but you need to have it kind of in your mind. Otherwise you'll miss it, unless the woman is, pregnant. So there's questions and things you need to consider at admission. So for search for the etiology, as I mentioned, what is the medication? What were the dose? Has there been anything changed? What is history of substance abuse? Any mood disorder or suicide attempt that led to the ingestion? And any gastrointestinal side effects in addition to liver failure. And looking for any travel to endemic areas, any immunosuppression, any chemotherapy, any history of autoimmune disease, and then looking if their patient could be a liver transplant candidate. And also understanding the interval of time of symptom onset and development of jaundice and hepatic encephalopathy can also be quite helpful. So in terms of laboratory analysis, you're going to assess for disease severity. So you're going to check your synthetic dysfunction, including your INR. You're going to look at your transaminitises. You're going to follow renal function, arterial blood classes, lactate, and arterial ammonia. So arterial pneumonia really has the best prognostic yield or diagnostic input is actually an acute liver failure. So it's prognostic depending on how high your ammonia level goes, and it correlates with intracranial hypertension and cerebral edema. So it's really important to get it up front and then follow it serially. And then you want to check for other etiologies. So your viral, work up your toxicology screen and look for complications, so anything to do with the pancreas. And then in terms of monitoring the patient, you want to make sure there's no infection, so blood cultures, get your best baseline chest x-ray, EKG, liver ultrasound with Dopplers, EKG, and you want to monitor them clinically. So put them in a monitor setting, do serial neurological examinations, and make sure you're following end organ function. And then standard of care, these patients are often hypoglycemic and need glucose infusions of 10 to 20%. You can consider giving them stress also prophylaxis. You don't need to correct their coagulopathy with blood products unless they're actively bleeding. And you should consider giving NAC pretty much in all of these cases. And you want to prevent any sedative medications, and you want to avoid any hepatotoxic, nephrotoxic drugs. So if a patient has hepatic encephalopathy, you want them in a monitored setting, ideally ICU, because they can deteriorate very quickly. And once they deteriorate, you have to intubate them as you would anybody with possible increased ICP, and keep them head to bed at 30 degrees in a neutral position, intubated, ventilate, and sedate to if they have hepatic encephalopathy grade 3 or more. Generally with people with liver disease or acute liver failure, they die of bleeding, cerebral edema, and infection. So need to be diligent in looking for that. And you want to try to normalize their biochemistry as much as you can. So in terms of immediate criteria, the transplant center will want to know their King's College criteria for acetaminophen, if it's acetaminophen toxicity, or non-acetaminophen scores, and that's there for you. And then you want to transfer to a specialized unit early. And ALF, it's not a linear development. People can be fine and stay fine, or within the span of a couple hours, crump pretty hard and die. So you need to make sure they're in a safe environment, that they have senior clinical overview. So that means that once they're in the ICU, that you're seeing, the attending is seeing them twice a day at minimum. In the emerge, the attending is seeing the patient as well, and making sure that you're following their physiological parameters and blood results and metabolic status, and follow their urine output and their renal function. So in terms of specific management, so from a neuro perspective, you have to really worry about cerebral edema and intracranial hypertension that can result in bleeding. That's usually at ammonia level greater than 150 to 200 is where you see that peak. So it's useful to follow that. So metabolic wise, they have hypoglycemia, hyponatremia, hypophosphatemia, hyperkalemia. Renal, they can go into acute renal failure needing early renal replacement therapy, and pulmonary wise, they can develop ARDS and pulmonary overload. Hemodynamic wise, they can actually develop a hyperkinetic arrhythmia, and infections they can also develop. So most patients present with acute liver failure, severe acute liver injury, often develop systemic vasodilation with reduced blood volumes. So you do want to ensure that they were adequately resuscitated, but not going crazy with over resuscitation of these patients. And if they're persistently hypotensive, you will start vasopressors, and Levofed is the pressor of choice. And this is reflective across guidelines. It's also in the ASLD guideline, as well as the SCCM guideline for liver management and surviving sepsis. And if there's an element of hypoxic hepatitis, then they might need inotropic support as well. There's no clear defined target for blood pressure management in patients with liver disease. In other guidelines, they use indirect evidence from the sepsis literature and using a MAP of 65, but there's no specific one for liver disease. And hydrocortisone therapy, you can use only if it's you have increasing pressure, vasopressor requirements, as you would in someone with septic shock, but it's not clearly indicated in someone who has acute liver failure. So in terms of airway management, so intubate as you would anybody with increased ICP or suspected ICP, and then you want to prevent hypercarbia and hypocarbia, and you want to make sure once they're in our unit, they're doing chest physio if they're still intubated. And with people with acute liver failure, you can feed them. Oral nutrition is better than nutrition via TPN because of the effects of TPN can have on the liver. And you want to make sure you're monitoring the ammonia levels, and if they're intubated, giving them stress ulcer prophylaxis. And then acute liver failure is frequently associated with electrolyte metabolic derangement. So again, looking for the hypoglycemia and hyponatremia, the acidosis, and alterations in the electrolytes, and replace them accordingly.
Joe, can I interrupt with a question?
Sure.
So I just have a few questions from the chat board. So I'll be moderating them and then asking periodically if that's okay.
Yeah, that works for me.
So one of the chat group was in terms of just regarding the dose for NAC, if it's a non-Tylenol acute liver failure, just wanted to, and if there's like a procedure for maintenance doses and different dosing for that. Can you just comment on that?
Yeah, so you can still use the acetaminophen toxicity protocol in people who don't have acetaminophen toxicity. You can use the same protocol.
Okay, and then I have another question. Would albumin be used early in resuscitation for patients with acute liver failure versus other non-GI, like acute liver failure cases?
So that's a great question. I tend to use albumin earlier on than crystalloid therapy. That's more based on the evidence from the acute on chronic liver failure population that we have more experience with. If you read the guidelines, they suggest crystalloid first, as you would with anybody else. And then if you're finding that you're having to give more, you can give albumin at that point. But your primary resuscitation fluid first should be crystalloid based on guidelines.
And then last question, you had mentioned arterial ammonia as a good prognostic marker for acute liver failure. Is venous ammonia useful at all, or are you specifically looking for the arterial tap for that?
Both are helpful. So whichever one you can get. Sometimes there's a bit of a delay because they have to be batch shipped, and there's a bit of a lag in getting a result, usually a few hours. But I would get anyone you can get. If you at your center, if you can get venous, get venous. If you can get arterial, get arterial.
Okay, perfect.
But it's very important. And it's the only time ammonia is actually helpful.
Good to know.
I've gotten into fights about this, but based on the GI realm of literature, this is the only time it's really that helpful. So the other thing that is really important to monitor for, as we mentioned earlier, is acute kidney injury. So 40 to 80% of people who have acute liver failure actually develop AKI. And it is associated with increased mortality as well as longer length of stay in hospital. So the recommendations for ALF patients who develop acute kidney injury is actually for early initiation of renal replacement therapy with CRRT, probably earlier than you would in your traditional patient population. It helps regulate the volume. It helps with ammonia clearance. We've done some research looking at that, and that seems to be effective. And renal replacement therapy helps you regulate the metabolics a bit better. So if you need to do it early. So coagulation and management, really high INRs are very scary to see. If the patient is not bleeding, you do not need to correct it. And it's important to actually follow an uncorrected INR because it has prognostic implications. And in terms of transfusion targets, so a lot of this is based on the Villanova trial, which we'll mention in the other half of the talk. And your transfusion target should be 70. So hepatic encephalopathy, really very ominous sign in this patient population, and it may progress from just a trivial lack of awareness to deep coma relatively quickly. And you see headaches, vomiting, asterixis, agitation, hyperreflexia, and clonus on the spectrum. And you really need to screen frequently for it, otherwise it'll be missed. And patients with ALF, as I mentioned, have an increased risk of infection. So you should be screening for infections as well and have a lower threshold for starting antibiotic treatment. And in terms of hepatic encephalopathy, they do have prognostic impact. So once you're grade 3, you should be intubating that patient to prevent aspiration and easier transfer to transplant centers. And on progression of grade 4 encephalopathy, so you want to make sure that if you need to use a sedative, you're using propofol as your sedative. That's what they use in transplant centers. And if you need opiates, you want short-acting opiates, not a continuous infusion, and you want to monitor for signs of seizure. In terms of intracranial hemorrhage and hypertension, we've actually had better outcomes in the last few years, probably due to better medical management and preventative measures from patients getting to that point, and the knowledge of knowledge of ammonia and its correlation. So those that have the highest risk of ICH are those with a hyperacute or acute phenotype, those that are young, those that have renal impairment and need for inotropic support, and those with persistently high ammonia. So again, you want to make sure you're following your clinical exam. Once they're in the unit, we can do cranial Dopplers if that's available at our center. Some centers have more fancy modalities, and they can do intracranial monitoring, which we don't have at our center. And as I said, monitoring the ammonia levels, the renal replacement therapy will take some of that out, and then renal and vasopressive support. If they have increased ICP, then you would treat it like you would any other case of ICP with hypertonic saline or mannitol. So you may read in the literature about bioartificial modalities. So MARS is one of them. So there's either a biological or absorbent machine. Actually, our CRRT machines in Hamilton have the ability to do extracorporeal liver support, but it's not recommended outside of trials, but it has shown some mortality benefit in patients who have acute on chronic liver failure. We published the systematic review, there you go, about it, but it's not used outside of trials. And if somebody ends up getting a liver transplant, they generally do pretty well. Their 1-year survival is about 80% at an emergency liver transplant. And really selection depends on the underlying etiology and other patient characteristics. So you need to be sick enough that you qualify for a liver transplant, but not too sick that you can't survive a liver transplant. So that's why contacting the transplant center early and immediately is key. And there's a variety of prognostic scoring systems. The King's College is probably the one that's used the most. And there it is again. So for emergency liver transplant, so acetaminophen, I remember it as a rule of 3 for those who, it may come up on exams, is lactate greater than 3, pH less than 7.3, hepatic encephalopathy greater than 3, creatinine greater than 3, and INR greater than 6.5. It can be divided by 3. That's how I remember. And acute liver failure not due to paracetamol is there for you. The Clichy we don't really use. It's more of a European score, but King's College, also European, is more frequently adopted. And this is just a slide that I'll provide you with slides of the talk where you can look at the prognostic values if you're so interested. And you really want to get people involved early and have a good idea of where patients are on their spectrum. So moving on from acute liver failure, I am going to talk about management of acute variceal bleeding. This is also something that is very scary, causes us all to clench various orifices as we have it. This is based on the most recent guideline, which is from ASLD in 2017. There are other guidelines that are more up to date. So EASL is better at updating their guidelines more frequently. So I tend to use EASL, but for the sake of this talk, I did the American. So cirrhosis is on a spectrum. In gastroenterology, we talk about cirrhosis as being compensated or decompensated. And in the decompensated stage is really where you start to see the variceal hemorrhage, ascites, and hepatic encephalopathy. And then late further decompensation is you get recurrent hemorrhage, you get refractory ascites, hyponatremia, hepatorenal syndrome, recurrent HE, and jaundice. And this is really based on pressures within the liver. So you get to be decompensated at a pressure greater than 12 millimeters of mercury. And that's where you start to see the acute variceal hemorrhages. I like this graph because it shows you how portal hypertension develops, as well as where medications start to impact. So as you remember from medical school and training, that your liver is generally a low pressure system. As the liver becomes cirrhotic, it becomes scarred, and that increases the pressures required to move blood through the liver. Then you get portal hypertension. And as a result of portal hypertension, you get varices, increased portal flow, and you get sodium retention, and then splenic vasodilation. And it's this vicious circle that we are always battling with our patients. So in terms of acute variceal bleeding management, number one is ABC. ABC is very important in acute variceal bleeding, as you all know. I think we've all walked into rooms that patients that look relatively fine, and they open their mouths and blood comes out and all over us. So these patients can decompensate very quickly, and it's really important to do your initial history physical examination while you're managing their airway, breathing, and circulation. For patients with acute variceal bleeding, I have a low threshold for elective intubation, just because I've seen when it goes wrong. My colleague Walid Al-Hazani, who's also a gastroenterologist intensivist, we tend to intubate these patients earlier than I think relative in normal spectrum you would. You want to make sure that you get large bore IVs, you start crystalloid resuscitation, and use restrictive transfusion strategies, so a threshold of 70, and then trying to maintain the hemoglobin between 70 and 90 in patients who are having variceal bleeds. This is based on a New England Journal randomized control trial by the Villanova group, which is kind of one of the biggest studies we have in gastroenterology. And this supports this background. You then want to start drugs. So you want to give octreotide or trelopresin if you have it. We were supposed to get it in Canada last year, and then a little pandemic happened and we don't have it yet. And then you want to have early diagnostic investigations. So calling gastroenterology to do an upper endoscopy and confirm varices. And you also want to make sure when you're starting your drug therapies that you give your octreotide, your pantoprazole, and your ceftriaxone. If you do not have a lot of access, which sometimes happens in patients who have variceal hemorrhage, especially recurrent, you can give the octreotide in a bolus of 50 and the panto in a bolus of 80, and then use the drugs or the other lines for resuscitation purposes if you don't have access to run the infusions, because very little is really nothing's compatible with pantoprazole. And then once the patient has been scoped, all the drugs have been started, you want to maintain the vasoactive drugs for about 3 to 5 days and antibiotic therapy for 5 to 7 days. And then determine if the patients are at high risk for rebleeding, then we should consider TIPS early. And those that have low risk for rebleeding, they can go on non-selective beta blockade and recurrent scopes to ensure these varices have been scarred down. So that's a nice summary slide. And in terms of the resuscitation, so securing the airway early, this is guideline supported as well, not just me and Waleed deciding this is what we want to do. And initiate and continue hemodynamic monitoring. So an ART line is helpful in these patient populations. You want to make sure you have 2 large bore IVs. 3 is better if you can get it in those patient population with those caveats I mentioned about the drugs. And you want to ensure the patient is in a monitored setting. So just one step back about PPIs and variceal bleeding. So the reason we give PPI and variceal bleeding is actually to prevent banding site ulceration. That's the purpose of it. And we generally give it for 72 hours and then we stop it. Patients don't go home on PPI. But I think sometimes that gets lost in the why we do this. So I just wanted to highlight that. Recommendation for blood products, as we said, a restrictive transfusion strategy is preferred in these patients and only transfusing once they get to 70 and then keeping them 70 to 90. you want to give ceftriaxone. It actually improves mortality in this patient population. Out of all the things we do, the one thing that actually improves mortality in these patients is ceftriaxone. So you give it 1 gram Q24 hours for 7 days, and then you can stop it. You could consider stopping it earlier for antibiotic stewardship if you have the hemorrhage has resolved and the vasoactive drugs have been DC'd. So there's different vasoactive drugs available that you can use in variceal bleeding. Traditionally, what we use in our center and across Canada is octreotide. You can use vasopressin if you didn't have octreotide, and trelopressin is actually the drug that's been most studied, more popular in Europe, not been available in Canada, but just so you're aware. And the octreotide, we usually keep it running more 3 to 5 days rather than 2 to 5 days. And it's a 50 mic bolus followed by 50 mics per hour. And the EGD should be performed within 12 hours once the patient is hemodynamically stable. If the patient's exsanguinating, you have to go ahead. And once the variceal source is confirmed, you would perform, or I would perform, the banding of the varices. And the challenges with these patients who are at high risk for rebleeding is whether or not they meet candidacy for TIPS. So TIPS we can get at our center. We do it at the Juravinski, not uncommonly. And it's usually people who have failed traditional banding, usually after 2 scopes, or are bleeding so much that you have the Blakemore in and you take it down, you still can't see to do the endoscopy. That person would have emergent TIPS. But you also want to make sure that you're selecting the right candidate for TIPS, and that would be speaking to gastroenterology and hepatology would make that decision. We have had to do rescue TIPS at our centers. I had a patient once who had TIPS bleeding. They had variceal bleeding, was banded, then bled again from the banding site, had a Blakemore in, and had TIPS within about 4 hours. So it can be mobilized quickly if need be. So then the post-hemorrhage, how do we manage these patients? So post-hemorrhage in patients who have large varices and are banded, they should be on non-selective beta blockers because the decreased risk of rebleeding if you use 2 modalities together. Traditionally, we use nadolol. For patients who have both cardiovascular disease and have varices, we will traditionally use carvedilol. It's also been used in this patient population. So sometimes we go in thinking this is a traditional esophageal variceal bleed, and we actually find gastric varices. If you're a GOV1 and you do banding at the GEJ, you could potentially help with the bleeding from that site. A little bit with GOV2 as well, but these other sources of bleeding very rarely will banding of esophageal varices be a benefit, and then patients actually need to be glued. In our center, it requires 2 gastroenterologists to perform gluing, so it's not something that's done in the emergent environment, and there's only 3 people at our center who actually do gluing. So just to have that in the back pocket. And if patients have gastric varices, you do treat them otherwise the same as you would an esophageal variceal bleed. So you give them octreotide, antibiotics, vasoactive drugs, and in a monitored setting if they're any hemodynamic instability. And then once they're stabilized, they'd go for gluing. And if patients continue to hemorrhage with gastric varices, then you would also move towards a TIPS or a balloon retrograde therapy. So Blakemores and Minnesota tubes. So Blakemores, anytime anybody calls for the Blakemore, it's very dramatic. Everyone's really stressed. There's usually crowds of hundreds around and you're sweating buckets, your hands can't work anymore. It's a very stressful situation. There's different tubes. So there is the esophageal, there's the traditional Blakemore tube. So it has an esophageal balloon and a gastric balloon. It generally requires about 250 of air in this balloon and about 50 in the esophageal balloon. It does vary depending on the make and the model of the manufacturer. The thing with the Blakemore tube is you actually have to put in an NG tube as well which is a bit cumbersome while you're trying to put this big hose in someone's bleeding esophagus and, you know, the cast of thousands around you watching you patiently as you put it in. The Minnesota tube, so that's what we have at Hamilton Health Sciences. We call it the Blakemore, but it's a Minnesota tube. So this could actually go up, the gastric balloon can go up to 450, 500 cc's. The esophageal balloon usually goes to about 100, again, varies depending on the make. And it has an esophageal aspiration port, which is great because you can tell if they're still bleeding from their esophagus, as well as a gastric aspiration port. The Linton tube only has the gastric balloon. I've never actually seen it in use, but it does exist. And this is your Blakemore tube. This is the Minnesota tube. So you have your esophageal aspiration channel, your esophageal balloon, you have your gastric aspiration channel, and your stomach balloon. So the real indications for this is uncontrolled variceal hemorrhage. And so complications that can happen, they're rare, but they can, and they're terrible complications to happen, is you get esophageal rupture, esophageal ischemia, hemorrhage, aspiration, pressure necrosis, airway obstruction, and can worsen respiratory failure. Patients who have hiatus hernia, that's a relative contraindication because you don't know if the balloon is actually in the hiatus hernia or it's actually below the level of the GEJ and arrhythmias. So before you put it in, again, it's very stressful. There's usually blood everywhere and there's stuff all over the floor. It's very dramatic. Looks like a scene out of ER, the old TV show. Only we're not, our scrubs aren't handmade for us. So you want to ensure the patient is intubated and sedated. You want to have your equipment available, know what you have. So by looking at the tube, even when you're stressed out, you can tell if it's a Blakemore in Minnesota. You want to have the MacMaster. You want to have large volume syringes, traction system. So you can use a helmet, you can use a weight, you can use a 1 liter bag of fluid. That's usually the one we have readily available, though the catcher's mask should be in the Blakemore kit, clamps, 60 ml syringe, lubricant, cling, and you want to have forceps. And you want to, before you put the tube in, make sure that the tube doesn't have any leaks. So blow up the balloons, test it underwater, because sometimes they sit around for a while before being used. And you want the patient either supine, usually they're supine, or in left lateral decubitus. You want to place it through to at least 70 centimeters. Once the tube is in place, suction the air out, inflate the gastric balloons to 100 mils of air, get your chest x-ray, ensure the placement of the gastric balloon is below the level of the diaphragm. And once confirmed, you can pump it up to 400 mils of air if you have Blakemore. And once inflate, you want to clamp the gastric balloon, then pull the tube until you feel resistance at the level of the GEJ. And then you want to ensure hemostasis. So checking your esophageal port, your gastric port for aspiration. The Blakemore is only temporizing measure. It's a bridge to something. So it's a bridge to re-look endoscopy or bridge to TIPS. So it can't be in there very, very long. And the balloon should be deflated every 12 hours to assess for bleeding. And if no further bleeding occurs, you can deflate the balloon. So this is a picture of the balloon below the GEJ with traction and without traction. So in terms of using the esophageal balloon, I've only had to do it 3 times, having to use the the esophageal balloon. 98% of the time, the gastric balloon alone buys you time. But if you're still having a lot of blood come out despite the gastric balloon in situ, then you have to actually inflate the esophageal balloon and apply it under pressure. And then that pressure needs to be alleviated every 4 hours to ensure that you don't develop esophageal necrosis. And this is all happening at the level of the ICU. I do a lot of in-services about Blakemores, and the best video is EM Quit. Highly recommend it. It's great if you want to see it. So for the last 10 minutes, I'll just go through the non-variceal upper GI bleeding. So this is based on a recent guideline from the Canadian group, Alan Barkins at McGill, and lots of McMaster persons, Francis C., James Duquetis, Gregoris Leonidas, and John Marshall. So same thing with variceal bleeds, resuscitation is key. So making sure that someone with acute upper GI bleeding and who have hemodynamic instability, you want to start resuscitation measures immediately. And you can calculate the Blatchford score. This is from MD Calc, so you don't have to do it in your head, which is always great when you can offload cognitive burden, to identify those who are low risk for rebleeding mortality and may be able to have an upper endoscopy out of hospital and not as an inpatient. In terms of resuscitation, risk factors, and pre-endoscopy management, I'm not going to go over endoscopy management with the group today for time purposes. You want to identify those who are at low risk and high risk, but they don't recommend using the AIM-65 score. You can consider placing a nasal gastric tube for patients who are bleeding that may have some prognostic value. If there's a concern, is this an upper GI bleed or is this a lower GI bleed? And in terms of hemoglobin thresholds in this guideline, so there was some debate on the guideline committee. They had cardiologists, gastroenterologists, hematologists, no ICU doctors. I pointed that out to Dr. Birkin. I would have happily been part of this guideline, but they did not have it's a little bit wishy-washy in their targets. So they used a target of 80. So, and particularly those who have cardiovascular disease, based on the evidence of the TRIC trial, you want a slightly higher hemoglobin target, so above 80 in patients who have known cardiovascular disease. So in terms of patients who have acute upper GI bleeding who are receiving anticoagulation, so this is a huge issue of like, do you revert it? Do you get the DABI bind? And do you have any reversal agents? While you're doing that, that still shouldn't delay endoscopy and diagnostics and management of GI bleeding. And it's pretty clear in that guideline, depending on, you know, if patients are on DOACs, vitamin K agonist, or they're on dual antiplatelet therapy, you still can do your upper endoscopy safely and provide management while you're trying to get reversal agents. Pro-motility agents are not routinely used. It may be on the gastroenterologist's preference whether or not they use it or not, but it's not required from a guideline perspective. And those that have an upper scope, you see where they're bleeding, it's clean-based ulcer, things look fine. Those patients can be discharged after endoscopy, which I think is an important consideration given the pandemic climate that we're all dealing with currently. Trying to get people in, assessed, managed, and out is even more pertinent now than ever before. And the use of PPI therapy in your non-variceal upper GI bleeding, it may actually downgrade your lesion by the time you do the upper endoscopy and the need for endoscopic intervention. However, if somebody's really bleeding and fast and you can't get it, it shouldn't delay the endoscopy. H2RA should not be used for acute GI bleeding. It should only be PPIs. The use of somatostatin and octreotide are not routinely used in this patient population because it's a non-portal hypertensive source. And for patients with bleeding ulcers with high risk stigmata who undergo successful endoscopy, so these are people who have a spurting vessel on the scope, large amounts of blood, those patients actually need the PPI infusion for 72 hours of 8 milligrams per hour. Patients who have less of a high risk stigmata, they can just do PPI, IV, BID, or even orally BID. But patients who have high risk stigmata must be on a PPI infusion. And once patients have completed their high dose PPI infusion, they can actually be on twice daily oral PPI for 14 days, then once daily moving on. And patients should be discharged with a prescription for a single daily dose oral PPI for duration as dictated by whatever their underlying cause is. And once patients are at high risk for rebleeding, they can be fed within 24 hours. On the GI service, everyone's always so hungry. So we need to feed our patients more. And after they've had, for people with high risk lesions, usually they stay in hospital about 72 hours and then they can go home. If people have uncontrolled sources of bleeding, then we need a surgical consultation. And we're lucky at our center, we have excellent interventional radiologists who can do embolization and has saved many a patient from needing a big OR in order to fix it. Those that present with upper GI bleed, non-portal hypertensive cough, they should be tested for H. pylori and then receive eradication therapy if positive. If they're negative during their hospitalization, you should obtain an H. pylori test out of the acute setting to ensure they're really positive, because there can be some false negatives. So the other populations that you need to think about are patients with arthritis who are on NSAIDs, and really those should be switched to a COX-2 inhibitor plus a PPI in order to decrease the risk of rebleeding. And patients who are on aspirin who develop acute bleeding, they should be restarted on their aspirin as soon as possible. They've done studies looking at patients who have come in with acute bleeding, who have cardiovascular risk factors, and the risk of withholding their therapy is much higher than their rebleeding risk. Dr. Deborah Siegel is actually doing a study looking at prescriber preferences of when to restart anticoagulation after GI bleeding. It's called the Panther study, and that evidence is coming from locally trained woman investigators. So look forward to that evidence. But gastroenterologists in general, we will start earlier than even thrombo sometimes, because if we've seen the lesion, we've treated the lesion, and we're confident with our hemostasis, we don't want to increase people's risk of bad cardiovascular outcome. So also in secondary patients, so those on dual antiplatelet therapy who've had a bleed probably should be started on PPI. And those who have been on DOACs or warfarin who've had a bleed, they probably should be on PPI versus no therapy. So that was a whirlwind tour of GI emergencies. So in conclusion, acute liver failure. So remember, early assessment, have high index of suspicion for decompensation for this patient, have a broad differential diagnosis while trying to identify the etiology, screen for toxidromes, and do supportive care with ICU, gastroenterology, and transplantation. Poor prognostic signs, hepatic encephalopathy, and INR greater than 1.5. For variceal hemorrhage, remember ABCs, monitored setting, consider early intubation in this patient population. The EGD should be done within 12 hours and a transfusion target of 70. And make sure they have their octreotide, ceftriaxone, and PPI. And we went over briefly Blakemore, Minnesota tube insertion for refractory bleeding. And non-variceal upper GI bleed, again, remember your ABCs, you guys are expert resuscitative specialists, so you've got this. And an EGD in less than 24 hours, and use restricted transfusion targets and IV PPI of high-risk lesions, and always screen for H. pylori and complete eradication therapy. So with that being said, I just want to thank you all first for inviting me here today. And I want to thank you all as colleagues for all the tireless effort you have all put in during the pandemic. Truly frontline. It is an honor and a privilege to work with each and every one of you, from the emergency room residents to the emergency room physicians to all the allied health. And I know these are really tough times. And for those of you who've helped with the Protected Code Blue team and those doing extra shifts in ICU, I thank you from the bottom of my heart for everything that you do. So with that, I'll end. Thank you.
Thanks, Joe. Thanks for those comments as well. We appreciate that. We do have a few questions if you're okay to stick around.
Sure.
So a few of them. So the first one is one of our staff physicians had a case where there's a patient with psychiatric issues and also had an episode of hepatic encephalopathy, and it was tough to differentiate the two. So any tips on differentiating like psychiatric issues versus encephalopathy from hepatic concerns?
So that's a great question. So really looking at the grading scale. So screening for things like, do they really know where they are? Do they have sleep-wake cycle reversal? Do they have asterixis? Those symptoms are pretty specific for hepatic encephalopathy itself, especially the asterixis. And in that patient population, if you are really uncertain, some of these symptoms could be psychiatric overlay on top of hepatic encephalopathy, and they have true ALF, that's where the ammonia is helpful. So you have both a biochemical and a clinical assessment to go with. Great question.
And then just, I know you mentioned COVID in terms of London and having limitations. Has there been any changes to the transplantation process for liver failure because of the, the pandemic?
Yeah, that's a great question. So London was closed for a number of months, and Toronto was taking the backlog from London, and Toronto also is the transplant center for Winnipeg, and takes some of the Eastern Province patients. So it did limit transfer for patients for acute liver failure. I had 3 recently in the ICU, all different etiologies of acute liver failure. And really getting involved with the liver transplant service early, like literally do the consultation, 10 minutes later, you're picking up the phone and calling transplant. Like that's the sequence it should be in, because they're trying to make decisions for the entire province and provinces. So just be mindful of calling early, as particularly in the pandemic, because they'll be very honest with you, like, oh, this person needs to come regardless of anything else, or you know what, we're okay to wait. And you're not the only call they're prioritizing. So I think, did it change the amount of patients being transferred versus not? I don't know. The patients I had, one died, the other 2 recovered. So it wasn't as pertinent, but I do think it was really important to be even earlier in the assessments and contacting with transplant so they can actually plan their bed situation because of the overburden from London being closed.
That's great. One last question. Can you comment on the H. pylori serum test and if it has any role in the ED? Like the emergency department?
Yeah, I think it does. But if it's ordered, making sure there's someone to follow up on it, because it takes a while to come back. And if you've ordered, the biopsies are the gold standard, but sending off the serology, we would be doing it on the floor anyway. So sending it up front is not a bad idea. Just making sure that's communicated to the accepting service so they know to follow up on it.
Okay. Like if there isn't, say, an outpatient, someone who is suspected there's, they're not bleeding acutely, but we can send them to like an urgent GI follow-up. Should we be sending that off for the GI follow-up physician to look at, or should we leave that up to
and
GI?
I would put that, no, I mean, anything that can expedite patient care is always preferred. So as long as that's put on the referral that, patient is bleeding, has risk factors for Helicobacter pylori, so we're sending off the testing, please follow up on the results, that I think is reasonable.
And the last question to just add to that would be, does the test stay positive forever once you've had H. pylori once? Is it like an antibody kind of thing? Yeah,
it stays positive for a long time.
Is it a long time, like forever? So if someone had it like when they were 20, and then can that go negative again when they're like 50? Does that, you know what I mean? The serum test?
Yeah. Do you know what? I don't know off the top of my head. I'll follow that up. It does stay positive for a while, but it should become negative if you've had eradication therapy.
Okay, good to know.
And confirmation of eradication therapy is best with a breath test.
Right. Okay, I think that's it for questions. Thanks again, Joe, for your awesome talk. Please, everyone, remember to do the evaluation. But thanks for joining Regional Rounds today. The last thing is, in October 1st, we have our 10 a.m. conference, our local Emerge conference. So keep an eye on for that as well. But thanks again, Joe.
Thank you, everyone. Please stay safe, and I'll see you with the bleeds. Bye.
A lot of people are saying Golden Girls pick. They love it.
Thank you for being a friend, all of you. Really, in the middle of the night when we're resuscitating together, thank you for being a friend.
All right. Thanks, Joe.
You're welcome. Bye, everyone. Thank you.
Bye.